Hello, everyone, and welcome to the research webinar on massage therapy for recovery and lymphatic massage. So this is a joint presentation between the Massage Therapy Foundation and the National Certification Board of Therapeutic Massage and Bodywork. Welcome, everyone. We're really happy to have you with us.
Hi, I'm Dolly Wallace. I'm the current president of the board for the National Certification Board of Therapeutic Massage and Bodywork. We're excited to be here to be partnering with the Massage Therapy Foundation offering this webinar. Right now, we're busy focusing on growing our community of board certificates, so we'll hope you'll consider that in the future. We're also working on approved providers and reviewing their courses and making sure the content is still of the highest standards. We also offer specialty certificates. And with that said, I just want to welcome everyone again. And Robin?
Yep. So as I introduced, my name is Robin Anderson. I'm the president of the Massage Therapy Foundation. And I have two guests joining me today as part of this webinar, Kathleen and Dr. Horowitz. Kathleen?
Hi, my name is Kathleen Lisson. I'm a certified lymphedema therapist and a board certified massage therapist. I'm also an author and a Niktimba CE provider.
Hi, I'm Jeffrey Horowitz. I'm a plastic surgeon. I specialize in cosmetic surgery. I've been in practice for 20 years and I'm happy to be here.
Okay, just a little bit more about NCBTMB. We're a nonprofit organization. Our mission, we have a new mission this year, and it's elevating the massage therapy profession nationwide by establishing and advancing the highest credentials and standards of excellence. We offer programs, like I said, our board certification, and we really are promoting that and increasing the value for our board certificates, approved providers for continuing education. We're also hoping to get some new providers on board, and like I said, we're going over the content of what we're offering, making sure it's still of the highest standards, and we also offer specialty certificates. So for more information on any of this, visit www.ncbtmb.org.
And just a little introduction about the Massage Therapy Foundation. We are a nonprofit organization as well. Our mission is to advance the knowledge and practice of massage therapy by supporting scientific research, education, and community service. Some of the projects that we support at the foundation, you've probably heard us mention the ergonomics report that is in its process of being rolled out. We support community service grants, research grants. We also support contests for student case reports, but we also provide a lot of resources, educational programs that help to foster research literacy. We're really supportive of schools and educators. So research is our hub. If there's any place you want to find research, good information, that's who we are. And for more information about that, you can go to our website, which is www.massagetherapyfoundation.org. We also sponsor and support the International Journal of Therapeutic Massage and Bodywork. This is the official journal of the foundation, as well as our partner, Registered Massage Therapists Association of British Columbia, or RBMTBC. Gosh, all these acronyms. Anyway, it's a free open access journal. It's peer reviewed. We're very pleased to have our editor, Dr. Ann Blair Kennedy, serve in that role, as well as many other section editors that are just experts in their field. It's PubMed indexed, and it provides a lot of great information about what's happening in massage therapy research today. So this webinar that we're presenting today is a collaboration with us and the National Certification Board. Dolly, we both share this commitment to advancing the standards of the profession. We do it through research, and you do it through quality education and quality certifications and certificates. So today we want to provide massage therapists, and maybe we have some guests out there who are not massage therapists, but we want to provide you with opportunities to enrich your knowledge about research. And today's webinar is specifically about manual lymph drainage techniques and how it can be used in postoperative recovery. We're going to focus on safe practices and guidelines, the basic mechanisms of how the lymphatic system works, as well as how to work in collaborative practices and developing partnerships with physicians. And to be clear, And to be transparent, Dr. Horowitz I actually practice in his office, which is why I invited him to join us today. My practice is focused primarily on manual lymphatic drainage, and so is Kathleen's. So that's why we bring these perspectives into today's webinar. Now you can earn 1 continuing education credit. As you know, Massage Therapy Foundation is an approved NCBTMB provider. So we will give you more details on how to access the quiz so that you can earn a free CE for today's webinar. Now, if you want to ask some questions, please go ahead and put questions in the chat box. And towards the end of the webinar, if we have some time, we will certainly try to answer as many questions as we can. So let's go ahead and get started. Kathleen, the floor is all yours.
Thank you. Thank you so much. So we have 2 good diagrams, and I'm going to talk about those diagrams, but let's step back and first talk about what is the lymphatic system. This may not be something that we really went over in massage college, and certainly not in our high school biology. So the lymphatic system moves fluid and cellular waste products from our tissues back into our bloodstream right here into our body circulation for processing. So many activities can affect the lymphatic system, and we've heard some of them like exercise, calf pumping, joint movement, deep diaphragmatic breathing, and elevation of certain body parts. And as far as massage, putting a skin stretch on the skin helps open the initial lymphatics. It's that skin stretch movement of MLD that we're looking to use to help someone after surgery. So we can look on the right, the model that has those blue lines. Those blue lines are watersheds. So watersheds show the areas of the body that drain to a region of the lymph nodes. So you'll see the lymph nodes are in where those red arrows are pointing to. And then on our left, you see these red lines. The red lines are the anastomoses. These are areas where lymph can more easily be transported from one watershed to the other. So if we need to get something from the right side of the body to the left, we're going to use that anastomoses. Not all manual lymphatic drainage is the same. We'll definitely talk about that more later, but I just give you the first resource is if you look on the close training YouTube page, there's a video called Effective CDT and Inconvenient Truth, and that will give you really good visualizations of different types of MLD and what is more effective and what is less effective. Thank you.
CLT versus MLD certified. There is a difference in training and scopes of practice. Certified lymphedema therapists can work with patients who have been diagnosed with lymphedema. There's more advanced, extended hands-on training and dietetic study, extensive certification exams, LANA. Lymph nodes have been removed and bandaging can be done. All this depends on state regulations, of course. A certificate in manual lymphatic drainage cannot work with patients who are diagnosed with lymphedema. Typically, a full 5-day plus training with practical and written exams is what you take to get your certificate. Patients are generally healthy individuals opting to have elective procedures. And again, it depends on state regulations. Both Robin and Kathleen do lymphatic drainage, but they both have different qualifications.
Yes, that's right. Dolly, I have the certificate in manual lymphatic drainage, and part of the reason why I work in a plastic surgeon's office is because I am working with healthy individuals that have been cleared by the surgeon to have these elective procedures, and so my scope of practice is just with healthy patients. But Kathleen, you have the CLT, so explain what you do and how you work with patients.
Yep, so I entered into the massage field as an oncology massage therapist. That's where my heart is. And so I wanted to take that extra step, to take the extra training, to know what people with lymphedema were going through in each part of the treatment of their disease. I do not treat the disease of lymphedema. I'll do with the decongestive therapy or the wrapping, that is something that can be covered by their insurance. But I, as their therapist, definitely want to know about it. And I can also take clients who have reconstructive surgery on the breast and then liposuction for fat transfer to their breasts. I can help them with the manual lymphatic drainage for the liposuction area after that type of surgery.
Yep. So that's just it. There is a huge difference between working with somebody who's recovering from breast cancer and reconstruction and that have lymphedema as an issue, as opposed to someone who has swelling and edema that's post-operative, who's done an elective procedure. So there's definitely more ramifications involved. And wouldn't you say, Kathleen, that you work as part of a healthcare team? You're talking to more than one doctor when you're working with somebody who's a cancer recovery patient, or, someone who's working or coming from that aspect?
Yes, when I'm treating, so I will help people after facelifts and liposuction and, tummy tuck and Brazilian butt lifts, and that I'll talk just to their plastic surgeon. But there is definitely a higher standard when you're taking a client who's having reconstructive surgery. You have to be able to talk with their oncologist if they're still on some kind of drugs, which often people with breast cancer are for that 5-year period after their cancer is treated. So there's just a lot more moving parts, just to be aware of it and understand who's at the head of the client's care team and work as a part of that care team. Absolutely.
Yep, absolutely. And then, of course, you always have to remember your scope of practice in your own state. And just want to mention the LANA that's in parentheses there. That is a national exam that is on lymphedema specialization. So massage therapists can take that exam, but also physical therapists, occupational therapists. So it's healthcare providers that take that level of training. And that's why a CLT also has more advanced training, is because of that scope of practice that they have versus somebody who has a certificate. I'm so glad you brought that up, Dolly, because I think it's really important for people to understand that.
Absolutely.
So if you had a client that had an plastic surgery, but they had a cancer history, that might be a way to get to know a CLT in your community, so you can refer those cases to him or her, to them.
Also, if you're interested, there are advanced trainings. NCBTMB offers approved training through, you'll read the ones below, Academy of Lymphatic Studies, the Chickley Health Institute, individual classes at Close Training, Norton School of Lymphatic Therapy, and some other training that's available is VADR International. So if you have any questions about those, you can always get a hold of us. And if this is the type of work you want to do, these are some of your resources for it.
Great. So let's actually get into what are some of the cosmetic procedures and how MLD can benefit from that. So we're going to turn the floor over to Dr. Jeffrey Horowitz.
Okay, thanks, Robin. So these are the most common procedures that a plastic surgeon would refer to a lymphatic massage therapist. And the way you could think of these is the damage to the lymphatics indirect, meaning blunt trauma, or are the lymphatics actually surgically divided? So in the blunt category, we're talking about liposuction. And in the next slide, I'll tell you how we go about doing that. The more common excisional procedures, facelift, and body contouring surgery, such as tummy tucks and thigh lifts, where number one, the lymphatics are surgically divided, as opposed to the blunt trauma from liposuction. And furthermore, plastic surgeons love to put incisions in creases. So unfortunately, that also means, as I'll show a slide later, that that crease might be near a nodal basin. So not only are the lymphatics being divided, but they're close to the drainage nodal basin as well. And I should say, a lot of times we combine liposuction and excisional procedures. It's almost routine that we do liposuction to the abdomen and a tummy tuck at the same time. Most patients that need a tummy tuck could also benefit from liposuction. Most times for facelifts, we do some liposuction to the neck. So these things are often, the blunt and the direct trauma is often combined. So how do we do liposuction? So the classic liposuction technique is that you have a metal wand that's connected to a suction machine that suctions out the fat. Prior to the suction, we inject what's called a tumescent fluid, which is absolutely necessary because without the epinephrine in the fluid, there would be tremendous blood loss. So after we inject the fluid, we do the suction. Now, more recently, researchers have endeavored to add some form of energy to the liposuction procedure, be it mechanical, ultrasound, or laser. I myself use mechanical energy, which is called power-assisted liposuction, which means that the wand vibrates back and forth. So from my point of view, I don't have to push so hard, and that's good for me because there's less fatigue, and also the surgery can be accomplished more quickly. But for the patient, because there's less trauma, they have less pain, swelling, and bruising when you use power-assisted when compared to the original versions of liposuction. Okay, so Klein, Jeffrey Klein is a dermatologist. He is the father of Gemescent Technique. He is a dermatologist. He invented that technique. He wrote a textbook about liposuction, and he described what it does to lymphatics. So the trauma to the vessels causes the capillaries to become more porous. So when the capillaries become more porous, the larger plasma protein molecules can escape into the interstitium. The fluid follows the protein, and that creates edema. If that edema lingers, I think, Kathleen, you're going to talk about this later, but if that edema is not resolved, it can linger and eventually become fibrotic, which could be difficult to correct. So in addition to those mechanisms, overzealous injection of tumescent fluid can be a contributing factor. The way most plastic surgeons do the tumescent fluid is we aim for a 1-to-1 ratio, meaning we try to anticipate how much we're going to suction out and we try to inject that volume. Of course, it's hard to say because we have to inject first. So you don't know exactly how much you're going to suction out, but that's what we shoot for. There's another technique which actually has a 3-to-1 ratio. So for that technique, you're injecting quite a bit of tumescent fluid. So if you don't suction all that out, the body either has to absorb it or it's going to linger and contribute to the swelling. And this is a topic near and dear to my heart, external compression garments. So I myself, I do not recommend compression garments. I provide them. If I don't provide them, lots of patients who've been on the internet, they're going to say, where's my faja? So rather than having to answer those questions, I provide it. And of course, I'm not against it if the patient likes it. A lot of patients do, and it makes them feel supported. But the bottom line is, in my opinion, it does not make your result any better or any worse if you wear it or not. And when you think about it, how can you wear something external to your body that will compress your body into a shape that it will maintain permanently? It just doesn't make any sense. Your result is going to be determined by what your surgeon does for you. Yes, if you're wearing the garment, it'll prevent swelling while you're wearing it, but the moment you take it off, you're going to swell. Furthermore, so in my opinion, not only does it not help, but it could actually hurt. Because if the garment is too tight, it could actually physically compress the lymphatic channels and it could actually hurt your result.
Yep.
So I just want to show the slide. This is similar to the slide Kathleen showed prior. So the curvilinear line down in the lower abdomen, that's the typical tummy tuck incision. The diagonal lines in the groin are the typical thigh lift incision. So you can see how close these are to the inguinal lymph node basins. And it's not uncommon that we do both of these at the same time. So if you can imagine, you know, the effect on the lymphatics in the groin.
That tends to be a common area where people have fluid collection too, and swelling is right around those incisions too.
Yeah, especially with the tummy tuck, you know, the swelling is going to collect by gravity, and it's going to collect right there, and all the divided lymphatics are going to contribute to that swelling. It could get tremendous swelling right there. It could be very hard. It could be distressing to the patients. Yeah, so that's probably the #1 reason why I think lymphatic massage is very helpful for that specific area. The patients are obviously, you know, they're concerned because sometimes after tummy tuck and lipo, they may not even look all that different in the beginning, and they're like, you know, they're concerned about the swelling, especially if it's very hard. So I think this is, you know, very helpful to get the patients through that period of swelling more quickly and with less pain. Okay, so I should tell you there is no consensus about when to start lymphatic massage therapy, but in our practice, I feel after liposuction, 4 days is reasonable, or when the patient can tolerate massage. And obviously that's different for every patient, but in my opinion, most patients on post-op day #1 will likely not tolerate massage. If there is a wound healing problem, you know, we will hold off until it's healed. Tummy tuck. the drains have to be out, and they certainly cannot have a fluid collection. The fluid collections in my mind cause a concern because if you were to massage it, the fluid creates a cavity. So if you massage the roof of the cavity down to the floor of the cavity, you can create shear forces, which in my opinion can create more seroma fluid. So once the drains are out and once we're certain that there's no seroma fluid collection, then they're safe to undergo massage therapy after tummy tuck, maintaining the patient in a semi-Fowler position. So facelift, I tend to wait longer because it's almost par for the course that patients will swell, especially under the chin is almost routine. And this will resolve in some patients. So I tend to wait a little longer for patients, but if it's obvious it's not progressing as quickly as we would like, then in about 2 or 4 weeks, we will refer the patient. So the key thing about this slide is, unfortunately, the evidence to support these therapies are mostly anecdotal. We did a search of these common online study directories, and unfortunately, I could not find any legitimate, prospective, randomized, double-blind, controlled studies that that provide strong evidence for that would support lymphatic massage therapy. Furthermore, as I mentioned before, there's no consensus amongst my colleagues about, number one, when to start it, number two, how many treatments, and even if it's a worthwhile endeavor at all. In fact, in preparation for this webinar, I posted a question about this topic to our message board that's on the American American Society of Plastic Surgeons website, and the answers were all over the board, from people that do it immediately to people, frankly, that don't think it helps at all. So there's no consensus here. I did some research, right? And so this was one of the studies that I came across. So this appeared in the Indian Journal of Plastic Surgery, and I noted that a few references refer to this study. So they took patients that had both liposuction alone and liposuction and a tummy tuck together, and they treated them with both ultrasound and lymphatic massage, and they demonstrated that there were statistically significant reductions in pain, edema, fibrosis over time. The study was significantly limited, however, because there's confounding variables, meaning there's 2 groups of patients that had different procedures. There's no control group, which is key, and unfortunately, there's other confounding variables, including some patients had compression garments and some didn't. Furthermore, the way they assessed pain, edema, and fibrosis, it was subjective. So unfortunately, there were no objective measurements of these parameters. So unfortunately, this study is severely limited. So this other study was set up well. So they did have a control group. It was prospective, so it was well designed. They had patients that had either tummy tuck and liposuction together. One group of patients was not treated with massage, the other was, so it was well designed. But unfortunately, it was limited by the small sample size and the fact that they initiated the treatments relatively late. So they did find some small benefit, but unfortunately, due to the small sample size, it did not rise to statistical significance. So these are 2 textbooks that have sections regarding lymphatic massage therapy. The textbook on the left I own myself. This is sort of the hot topic in liposuction. High definition means that there's relatively aggressive liposuction that's done fairly superficially. The idea is you're trying to kind of sculpt the body as opposed to kind of the original thought about liposuction, which was to kind of just reduce the layer of fat evenly globally. This technique does much more aggressive liposuction in certain areas to sort of accentuate the underlying musculature. The other textbook is a textbook of liposuction, and the commonalities, they both recommend it. They think it's invaluable. In fact, both of these texts recommend that it's started preoperatively, which is interesting, but they think it sort of primes the pump, for lack of a better word, prior to the surgery. In addition, the authors of the high definition textbook mentioned some other benefits of the lymphatic massage therapy, which they listed as improved immune function, because they felt that the stimulation of the lymph nodes stimulates the immune system. Analgesia, because their thought is that the edema surrounding the nerves is decreased And also the lymphatic massage stimulates the parasympathetic system. So they thought the patients got some pain relief by virtue of doing the massage. They thought, as we spoke before, if there's less edema, they thought it led to less fibrosis. And if there's less edema, they thought that there's less of a distance for blood to travel before it gets to the cell. So they postulated that that improves tissue function and recovery. Unfortunately, it seemed like these were all, subjective factors, and unfortunately, they didn't provide any references to support these conclusions. Okay, Robin, do you want to talk about this slide?
So, well, actually, I was going to throw this to Kathleen because I know that we were thinking about how patients sort of expect, what their expectations are, and that's something that we share in terms of our partnership and you referring a patient to us when they come into our practice. So, Kathleen, why don't you talk a little bit about that?
Yes, this is one of my favorite studies. As you can see, they distributed this survey to 600 of their liposuction patients, and they were asking them, what are you looking for in your liposuction procedure? And found that it's different. Say if you're doing like an orthopedic surgery, you're looking for increased range of motion, activities of daily living. If you're doing oncological surgery, obviously you're looking to get the cancer, the tumor out. But if you are doing cosmetic plastic surgery, the responder's opinion of their appearance is the pivotal determinant in their satisfaction with their liposuction procedure. So we're really looking for results with this type of surgery.
Yep. And it takes a certain amount of emotional intelligence, doesn't it? I kind of feel like when I'm working with some of the patients that you're really their cheerleader. I mean, I love to be able to, when I start working on them and it's been maybe a week since I've seen them last, and I put my hands on them and I say, wow, you've really gotten the tissue's gotten a lot softer. You look great today. They want to hear that. And I don't say that, just off the cuff. I mean, if I can truly see that they are moving better, that their shape is starting to come along, you definitely want to reinforce that for them, because that was the whole purpose why they had this procedure, is to improve their body appearance according to what they felt needed improvement. So you have to try to sort of point that out and help to encourage the fact that they are making progress, because they may not see their plastic surgeon until maybe about 3 months post-operatively. So you have that time between like their 1 week post-op until, that 3 months to kind of like help them, sort of feel like they're in recovery mode, so to speak.
That is such a great point, Robin, because for so many people in my practice, maybe one person, maybe two other people, outside of their family knows that they had plastic surgery. This is something in Southern California, people like to keep very personal and to themselves. So the downside of that is their emotional journey is also, not being able to share the ups and downs and not having those frequent appointments with the plastic surgeons. The massage therapist is really the person that can reflect back to them, like on the second visit, oh, you're walking in like, with the spring in your step today. Like, how do you feel? Do you remember how you felt 2 weeks ago? And you're doing so much better today. Yeah.
Yep, absolutely. And Dr. Horowitz, you would definitely agree that clearly patients' expectations are pretty high when they come in, right?
Yes. Yeah. Well, that's my job. I always say to patients, your expectations have to be appropriate. If your expectations are appropriate, you're going to be happy. I could do the same operation, but if your expectations are too high, you're going to be unhappy. When I first started, when I evaluated a patient, I used to say, can I do a good operation on this person? I don't think that way anymore. Now I think, can I make this patient happy? Because like I said, there could be no relation between the quality of the result and the level of satisfaction of the patient.
Absolutely. Absolutely. Great point. Thank you. So Dr. Horowitz mentioned this about how the fluid collection can sometimes create, a sort of fibrotic or a firm feeling of the tissue. And so if you have not worked with a post-operative patient, from cosmetic surgery, when you first put your hands on them, you might actually say to yourself, what is that? What is that feeling? So, and it really is because those cannulas, those tubes that, or those instruments that the surgeons are using to suck out the fat, they literally create holes. And the left side picture sort of gives you a sort of a cross section of what those little areas or those spaces are left behind once you've taken out that fat. So it has sort of a honeycomb effect. So what happens is the fluid tends to fill in those spaces as the body is healing itself, but sometimes it can collect in certain areas and just linger, and that's where some of those firmer areas start to present themselves. And if it's there too long, it becomes fibrotic, which, you know, Kathleen will talk about fibrosis in a little bit. But it really feels different than other types of tissues. I mean, it feels, I mean, we jokingly say, oh, it feels like a washboard stomach, but it's not really that though. So, but it is firm like that. Next slide, yeah. Kathleen.
Thank you. Yes, sometimes some of my clients will say it like it feels like a leather jacket, like it feels I have a leather jacket on when they feel that stiff feeling.
Yep.
So that's a really great segue into this slide. And I really focus on, when I look at my client, I don't look at the surgery that happened and then the one type of treatment, which is manual lymphatic drainage. Because as massage therapists, when a client walks into our suite, we are treating the whole person, not just the symptom of swelling. So what else can our clients come in to see us and have concerns, whether they're verbalizing these concerns or whether you have to specifically ask them? A lot of people, if you've had a facelift, if you've had a Brazilian butt lift, if you've had a tummy tuck, they'll have back and neck pain from having to sleep in those individual positions to deal with their wound healing. Again, this tightness, some people say when they stand up, when they get up in the morning, it feels like they're pulling taffy. They can have swelling and bruising, and all these we can reduce with the types of massage with our hands that we have learned in massage school. We all know how to help somebody's neck pain and somebody's back pain safely after surgery. And if you have MLD training, you know how to reduce their swelling. And the big thing that I like to see clients soon after surgery, I like to have a relationship with their plastic surgeon where I feel super comfortable talking with each and every one of the plastic surgeons that refers their client to me, is that we're stopping problems before they get out of hand. Where I'm really, really open with the fact that I don't do everything. It is very easy for me. It does not damage my ego at all to ask the surgeon a question if I don't know the answer, to send the client back to their surgeon, to send them to their primary physician, to send them to a dietitian if they have questions about nutrition. Like, we have all these tools at our disposal. We are one part of the client's care team. And then we can also really be the stars of week in and week out. When we see these clients, we can reinforce their surgeon's post-operative care protocol. Like, oh, I see. I have clients that do Brazilian butt lifts all the time. I have one doctor, he really likes those Band-Aids on the incisions. Hey, I see you still have those Band-Aids on, like, you're doing great. And the client really, you can see their face light up with the pride that they are really taking this surgery and their recovery seriously, and they like to see that their massage therapist is seeing that too.
Yep. I know that that's the collaboration that Dr. Horowitz and I have, is because when I see some problems, I immediately run the red flag and say, hey, Dr. J, I saw this patient this week and this is what I saw. That person that can sort of be that supporting factor for the patient's care. And I know that Dr. Horowitz appreciates that too. So, because then that means that we're making the patient happy by keeping their care as a primary component. So.
Yep. And if I see anything visual that concerns me, you can have the client take their cell phone and you take the picture on their cell phone and you say, hey, just send it right to your plastic surgeon. The plastic surgeons that refer clients to me, their post-op care is second to none. They are very responsive to their clients. And that's one of the reasons why their clients chose them as a plastic surgeon, because they know they can rely on them for their recovery. So let's talk about draping and bolstering. There's a few things that we can do, and this is one of real favorite topic of mine, because again, like I said earlier, I started as an oncology massage therapist, and I feel like you graduate from your oncology massage class and you go out and instantly buy 15 pillows because you really want to keep people properly bolstered. So the general thing for the surgeries, I have the client lie supine, their head is on a pillow, they're completely draped by a sheet. The pillowcase can be used as a breast drape if you have to you do work on their abdomen. This type of massage, they do not need to be naked in any way. We can bolster and keep them safe according to state regulations, just the same as any other massage. If the client has a Brazilian butt lift, I prop them up with pillows and I use a rolled up yoga mat under their low back area, and then more bolsters underneath their knees, because the goal is to have no pressure on their gluteal area until they're sitting on their butt again. So whenever they've had the conversation individually with their particular doctor on when they're going to start sitting on their butt after the BBL, and then if they're still offloading, that's what I'll do for them as far as bolstering. Most clients, they love this. This is the first time that they've been on their back and felt safe since the surgery. If the client had a fat transfer to the thighs, we're not massaging while they're side lying. We're helping that fat transfer out until, usually I'll say for a lot of things, but also the breast augmentation, are you sleeping on your side? Does your surgeon say it's already all right to sleep on your side? And when they're already sleeping, for several hours on their side, I feel safe to put them in side lying. And if I see any foot or ankle swelling, I always use a wedge to elevate their feet, and then I monitor them for any concerning changes in tissue quality. Again, this is back to the fact that I'm a lymphedema therapist and I'm always watching. We know some extra techniques to help the swelling in the legs and the feet, and they can definitely, if someone has foot swelling after surgery, I'm talking about their compression, I'm talking about if it's too tight, like Dr. Horowitz was talking about, and I'm showing them self-MLD procedures that they can do on their legs and joint stretching exercises to get that swelling down in the lower body. Okay, and then really quick, I choose which massage modality I'm using according to the client's stage of healing. So the first stage, we won't see them until after their blood is actually clotted. So we'll start into the inflammatory phase. And in that phase, MLD is going to help to reduce swelling, increase range of motion by using massage techniques that we know from school can increase range of motion according to the client's pain tolerance. So I have a pain scale on my wall and I tell them we're not going over a 3 to 4 and you have to let me know. I can always change my techniques. We can change how fast we're doing it. We can change how deep we're doing it. We can change the rhythm of our myofascial massage to make the client comfortable. During the proliferative and maturation stage, MLD is still useful. I'll begin and end all sessions with manual lymphatic drainage, but I'll also use fibrosis techniques that help the body to reduce the fibrosis naturally.
Yep, especially because at that point they're not quite that swollen anymore, and the concern is the scarring. Like, well, now the scars are healed, but are they going to get better? And so you try to make those a little more elastic, so that way they heal and they kind of get more invisible, if you will.
Yeah. But even if you're talking about fibrosis from liposuction, we prime the pump to get that lymphatic drainage system, our lymphatic system going and working. And then we do our deeper techniques. And the idea, as Dr. Horowitz says, it's proteins that need to be moved out of the area. So as we're moving around the fibrosis, we have to finish with the lymphatic drainage and actually get them into the lymphatic system. And that's what's really going to help. So excellent segue to get us into fibrosis. Fibrosis, as a lymphedema therapist, all of us are obsessed with fibrosis because that's actually the difference between treating someone with lymphedema stage 0 or 1 and stage 2 and 3, the more serious stages of lymphedema, is that the body has this load of fibrosis that's kind of overwhelming the effectiveness of just doing MLD. So let's read the slide. When acute inflammation is resolved, the lion's share of waste disposal is provided by our lymphatic vessels, and we've seen the watersheds earlier in the talk here. And these fibrinolytic enzymes dismantle the fibrin precipitates into their building blocks. So our body's enzymes are doing that, and they are removed into lymphatic vessels. So what goes wrong? Why is there fibrosis after surgery and it doesn't resolve by itself? If the fibrin precipitate is not completely removed and fibrin is remaining in the area of acute inflammation, the result is fibrosis, fibrosclerosis, and then eventually scarring. So that's the technical reason for why fibrosis is actually happening in the body. And like I said, the CLTs know that when fibrosis is present, we need more than just MLD to achieve results with these clients. We call, in the lymphedema therapist school, we call fibrosis massage deeper techniques. It's taught at lymphatic conferences. And very importantly, it's not deep pressure, bruising, intention massage. The focus is on changing the extensibility of the tissue, so we facilitate their skin stretch. So the MLD is not working well because you can't stretch the skin because of the fibrosis. So if we get the skin to stretch, then the lymphatic system can start working more effectively. Thank you.
And I'm glad you brought that up, Kathleen, because eventually we're going to talk about what MLD is and what it isn't. So, because there's lots of interesting information on the World Wide Web about that. So, next slide. So let's talk a little bit about contraindications for MLD. Go ahead, Kathleen, why don't you go ahead and start and then bring Dr. Horowitz into the discussion.
Perfect. So I have a really great practice, and Robin, I think you have a really great practice too, which is a surgeon refers their client to us for lymphatic massage. So I know that the surgeon looked at them and, you know, they don't have a seroma, they don't have an infection at the time that they were referred. So that's real, and it's the proper time and the surgeon is allowing it. So that would be my top contraindication. If the surgeon does not want that client to have lymphatic massage, like, then I am not giving you lymphatic massage against the surgeon's advice. Like, it's not good for you, it's not good for me, it's not good for anyone. But if they're approved and they book their appointment, they come in, I want to make sure they don't have an untreated infection. If something looks like an untreated infection, I'm sending them back to the plastic surgeon for treatment. And then once the surgeon says, yes, you can, you know, go ahead and book another appointment, then I'm booking another appointment. If they have fever, definitely, I don't know why they have a fever, but they're not going to be able to come in the office and give a massage till we figure out what's happening with their body. They definitely need to immediately contact their plastic surgeon. And the general contraindications at the bottom is really similar to what we do to protect a client that had lymphedema. If you have, we talked about seroma before, that the manual lymphatic drainage can actually negatively affect it. If they have acute infection, cellulitis, they think they have a DVT, they're having this below knee swelling, shortness of breath, that's making me think pulmonary embolism, or these more serious diseases, which they probably can't have and have plastic surgery at the same time, uncontrolled heart or kidney failure. These are all reasons to not give the massage and instead refer them back to their plastic surgeon.
And Dr. Horowitz, wouldn't you agree that, you know, definitely these are all conditions in which we would be sending them back to you, and that's beneficial to you?
For sure. And I think that's one of the good things about our setup is that, you know, you see patients here in the office, and a lot of times I'm here in the office as well. So we could have close follow-up and timely follow-up. Yeah, definitely. So, and I think I told you in the past that before we started working together, if I thought a patient would benefit from lymphatic massage therapy, I would refer them to a group in town. I really didn't know if they were qualified. You know, they had lymphatic in their name. And frankly, I had no follow-up. I could hardly remember ever getting any feedback at all, much less in real time. So yeah, it's definitely key to have close follow-up and timely follow-up.
And I think Dr. Horowitz just gave us the key to what I think is one of the reasons why the responses from plastic surgeons were all over the board when it comes to recommending MLD. If you don't have a provider that you can trust, I don't think that I would send somebody off to a stranger, especially, and I definitely wouldn't send them off to a stranger again if I never got any feedback. So it's definitely something as massage therapists, if we're doing this lymphatic massage, if we want to have these niche clients, getting, informing, and keeping that communication with the doctor is essential.
Yep, absolutely. So we've kind of alluded to this, so I kind of want to make this clear. What MLD is and what it's not in terms of approaches. So you've heard us talk a little bit about how we are approaching treatments. It is always a gentle application of strokes. So remember, these people are in post-operative mode, which means they're in a recovery phase. So anything that's going to be aggressive is probably going to be more traumatic for the patient or the client. So when we talk about MLD, when we talk about treating patients post-recovery or after, recovery from, post-operative surgery, we are thinking about facilitating the lymphatic fluid. That's a gentle stroke that happens. We're dealing with people who still have lingering pain and discomfort. So again, gentle strokes. So, and this is most often used in patients who have orthopedic procedures or cosmetic and aesthetic procedures. Now, I'd like to say a little bit about what MLD is not. And I'm sure maybe some of you have been on social media before where you've seen pictures of a patient standing up over, a drop cloth or something, or chuck pads if you work in a hospital, and you see that somebody aggressively massaging someone as the fluid just sort of oozes out of their incisions. That is not an appropriate approach to massage therapy or approach to manual lymphatic drainage. These are active wounds. It's going to be uncomfortable for the patient. And in my professional opinion, knowing what our scopes of practice are as massage therapists, I don't think it's in our scope of practice to do so. Wouldn't you agree with that, Dr. Horowitz?
For sure. I mean, I think number one, it can be dangerous. You're traumatizing the tissue, but more importantly, it's completely unnecessary. In my experience, in the beginning, the drainage can be tremendous, but it always stops after 2 days spontaneously. So it's just, like I said, it's couldn't be harmful when you massage the tissues that vigorously. You're crushing tissue. And like I said, furthermore, it's completely unnecessary. And it must be distressful to the patient. I mean, I don't think there's a patient that wants to stand over a drop cloth, like you said, and witness fluid pouring out of their bodies. It's, there's just no point.
Plus, again, they're taking pain medications. They're trying to wean themselves off pain medications as they're recovering. So we're trying to use massage for benefit, not for inhibiting or inhibiting recovery. So, and the other thing too is there's too many massage therapists out there who say that they can do lymphatic massage, and they're doing these aggressive strokes. And this is not a situation where this is a good hurt. Or how clients will say, when you do deeper tissue work, and they're like, oh, it's a good hurt. And this is not a situation where that is acceptable. You can create more damage than help the patient. Kathleen, wouldn't you agree with your experience with patients?
I just, from everyone I've talked to that has had massages that were too deep too soon after surgery, no one ever said it was a good hurt. People were saying they felt like they needed to take opioids before the next one. They were crying. They almost fainted. Like, I've just heard so many things that just break my heart as a massage therapist, because I did not get into this career to hurt people. I got into this career to help people and to look at the science and look at the expertise and use that. If you look at the high definition body sculpting book that Dr. Horowitz referred to earlier, they have an entire chapter. They have several pages where they specifically detail what they mean manual lymphatic drainage massage is. And when we're talking about pushing fluid out of incisions, that's not actually lymphatic fluid. Lymphatic fluid is inside the lymphatic system, and that fluid has not yet entered the lymphatic system.
Yep, absolutely. So, and these are things that you learn when you take those advanced trainings, when you take those approved CE provider courses. You learn these things about the lymphatic system. You learn about the gentle application. You learn about the anastomoses, and then also taking, a cue from the surgeons themselves who are referring their patients to you. So, and taking into account that they want a good result. So, and of course, using the research that we know about pain, which we have lots of research on that about massage therapy and its effect on pain. So thinking logically about how that's what this patient is going through. So going the aggressive route and using a soft MLD approach, soft myofascial strokes, those are definitely the way to go when you're working with these postoperative recovery patients. So as we talked about earlier, I mentioned that Dr. Horowitz and we work together, and I work out of his office. And I am very happy to be able to have that partnership with him in providing the best care for our patients collaboratively. But you can do the same thing as a massage therapist. You can develop a rapport with surgeons, as Kathleen has done. That's how you've developed your practice.
Yep.
So, one of the ways you can do that is to approach plastic surgeons and provide information on the benefits of MLD. So as Dr. Horowitz mentioned earlier, it's kind of all over the board, in terms of whether or not it's effective, or whether or not they would recommend it, or whether or not they would refer a patient to it. So if you establish some open lines of communication between those doctors and yourself, a lot of times you can start to create a nice referral network between the two of you. So the key is professionalism, having good detailed documentation, staying in communication with the doctor, keeping them abreast of patient progress, or if there's setbacks, sending them back to the surgeon for reevaluation. But you also have to speak the same language to the patients. If that's one thing that I think Dr. Horowitz and I do very well, is that I never contradict anything that Dr. Horowitz says to them, and he never contradicts anything I say. We speak the same language, we talk the same talk, and you don't want to contradict doctor's orders. Remember, this is the surgeon's patient. This is not your scope of practice to contradict the doctor's orders. You want to develop a collegial partnership, and the way you do that, and what's very it's a prevalent approach in medical environments today, which is called interdisciplinary communication or interdisciplinary approach. That is how quality patient care in many different arenas happen. So Kathleen, do you have anything to add to that, or Dr. Horowitz?
Yeah, one example that I would say of how we can help a client without contradicting the doctor's orders is around the faja. So the majority of my clients, they wear a faja. Most of my doctors will go along with my ideas for compression because I'm a lymphedema therapist. But I never contradict the doctor. I always say, go back to your surgeon and ask them a question. If you think that they don't want you to wear this compression, but maybe you do, ask them to have a conversation. Like, why shouldn't I wear this compression? Like, is it dangerous for me? Or do you just think maybe it won't have as big of a result as I think? So there's always, we're two medical professionals, and we don't need to directly contradict one another. We need to share ideas and get the conversation going in between the patient and the surgeon, because that's what the plastic surgeon wants, to have the patient have their best recovery possible.
Right.
Yeah, I agree. Yeah, I think communication is key. I mean, like I said, I'm not against the faja. I think if the patient likes it, it makes them feel supported. There's a lot of value in that. But where I'm coming from is, I think when some physicians say you have to wear this day and night for 8 weeks, I just think it's so onerous on the patient, and they're so uncomfortable. It's so, if it's warm outside, it could be very uncomfortable for them. And the bottom line, in my opinion, if you don't wear it, you're going to end up in the same place. Because like I said, in my opinion, your result is what the surgeon did for you, not what the FAHA would do for you. But I'm not against it. You know, if they like it and they're using it appropriately, you know, that's definitely valuable too. And that's key, because, you know, I do get a lot of patients when I say that, you know, their eyebrows go up, you know, you know, I saw on the internet you have to wear the FAHA, Dana, you know, and like, that's what I say. I say, God bless, you know, if you want to, that's okay. But I just don't want them to feel that they have to.
They have to. Yep.
Yep. And then they come into my office and they say, you know, Dr. Horowitz says I don't need to wear that. Is that okay? And I'm like, oh, don't put me in the middle here.
They want a second opinion. Yeah, for sure.
Yes, they do. They want to know. So, and that's where having that line of communication is important. I know what Dr. Horowitz's protocols are. I know how he approaches his patients. So I know what to say to a patient when they try to put me on the spot like that too. So having that interdisciplinary approach to each other, knowing the way I approach just as I know the way that he approaches with his patients, that we can speak the same language. And then the patient, even though they're fishing for information, they'll still get the same story. And that's important too.
Yeah, that's definitely key, because if we contradict each other, we're undermining the patient's faith in both of us. So, you know, we have to give consistent information.
Exactly.
Absolutely. Great.
Yeah.
Well, this has been a great talk. I mean, I really have enjoyed just having this nice chat with you all. Dolly, I hope you learned a lot too.
I did. This is amazing.
So how can our viewers earn a CE credit today? So what you can do is you can go to the massage therapy website and you can visit the resources section and click under webinars, and you'll be able to find the webinar there. We will also have the quiz active, so that way you can complete that quiz in order to earn the CE certificate, and the foundation will send your certificate of completion. But I want to thank everyone for joining us today. We're really surprised at the response of people who were attended this evening. So we really appreciate it, and thank you for joining us today. So Dolly, when is our next webinar? I mean, we've had so much fun tonight. I want to do another one. When are we going to do another one?
I do too. I'm so excited. And I also want to thank Dr. Horowitz and Kathleen. This was so informative. So for the future webinars, September 29th at 1 p.m. Central Time is our next one. And I'm really excited. It's going to be about sports massage in the Boston Marathon with Portia Resnick. So
yes.
Yeah, and she's just awesome. So
yes.
You don't want to miss that.
Yeah, she's a shared commodity between the National Certification Board and the Massage Therapy Foundation these days. She is one of the past presidents for the National Certification Board, and she's a trustee member with the foundation right now. And her expertise in sports massage is going to be perfect right around the Boston Marathon, which is coming up soon. Our 4 runners that are running for research. We can't wait. So thanks. I'm excited. It's coming soon. So if you want to connect with us, Dolly, how do we do that to find you all with the NCB?
You can just go to our website, ncbtmb.org. But if you have any questions on becoming a board certificate, we would love to welcome you into that community. And so we can help you with questions about taking the exam, how to get a study guide for it, whatever. Also, if you want to become an approved provider, or take one of our specialty certificate programs, just like you heard about today, you can contact us at info@ncbtmb.org. We look forward to hearing from you.
Yes. And Kathleen and I are both proud board certified and CE providers for NCBTMB. Yes. Well, if you want to reach out to the foundation, you can reach us at massagetherapyfoundation.org. If you're interested in reading more research in real time, you can certainly go to our journal, the International Journal of Therapeutic Massage and Bodywork at ijtmb.org. And then if you have any questions about our webinars, about our research grants, about our community service grants, the ergonomics project, or any of the resources, infographics, educational materials to support instructors, students, schools, you can reach out to our staff at info@massagetherapyfoundation.org. So, do we have any questions in the chat that maybe we have a few minutes that we might be able to answer a couple of questions? Do we have any?
Yes, we do have a few questions.
Great.
We have had several people ask whether pre-op preoperative lymphatic massage is indicated.
Well, I mean, that's just it. I don't think there's any evidence to support that. Just as there's not a lot of evidence, in general, to support lymphatic massage therapy, in general. I mean, I think, empirically, I think it makes sense to kind of prepare the lymphatic system. But, again, I don't think you could say with any certainty that it's necessary.
I would say it's everything that I had is anecdotal. I have given some clients preoperative MLD. They usually don't need as many sessions after the surgery. They're usually like, oh, this was great, everything went well. I would talk to your primary care provider if you were a client and you had some ongoing swelling issues before that, whether your ankles tend to swell, your face, your body tends to swell. And just see with your primary care provider whether that would be a good idea before your surgery.
Okay. Any more questions?
Yes, we got this question a couple of times as well. Do you have any recommendations for a therapist who receives a client who's had plastic surgery but does not appear to have a care team on their side? Perhaps they have received the surgery outside of this country, or they simply aren't in contact with their care team. How would you advise the therapist to deal with that?
I actually have had a few inquiries about that. Even though I practice out of Dr. Horowitz's office, I actually have gotten a few emails from clients who've either had their surgery done in another state or out of the country, and they're looking for an MLD therapist in their hometown. What I generally do is I tell them they need to have clearance from their doctor to have it. So before they leave, wherever they are, they need to get some type of clearance if they can get it. The other thing too is I'd also like their contact information for their doctor. At a minimum, I'd like to have that on record. And if I find any complications, just as I refer my patients back to Dr. Horowitz, I tell the patient to go back to either their primary care, or they have to talk to their doctor. Again, we have to think about scope of practice, and we have to think if there is a problem or if there is an issue and it's out of our scope of practice as a massage therapist to manage, it has to go back to a physician. There's no getting around that, whether the physician is here in the country or not. That's the risk that some of these patients take when they go out of the country or they go out of state. So, and I reiterate that with them when I take them on as a patient. Kathleen, what's your experience?
Yep. So right now, I limit my practice because I have 7 doctors that refer to me. So I can't take anyone that's not referred to me specifically. But a few years ago, when I had a more open practice, I was absolutely taking clients from Tijuana, taking clients from Miami, taking clients from Dominican Republic and Colombia. I have never had an issue with them contacting that surgeon's care team and getting the referral for lymphatic massage. Now, sometimes it's in Spanish and, you just translate, but usually they're open. My eyebrows would be raised if you absolutely could not get any information out of your care team whatsoever. If they really cannot get any information out of that care team, I really suggest they should go and get their checkup with their primary care physician. And at that point, the primary care physician can kind of say, yes, there's no infection, everything seems to be healing well. The client can definitely have lymphatic massage.
Yep. I think those are good practices. Okay, any more questions?
I've got a specific question on the safety of manual lymph drainage in a couple of different situations. So this question is it safe to do MLD if you do not work the nodes of the groin and axilla? Is that this question?
You mean axilla
in general? Pardon me?
You mean axilla area or
I'm sorry, axilla, yeah.
Yeah, okay. Kathleen?
I would really wonder why you couldn't. Like, that would be my first question, is why can't you? Because the answer to why you can't makes me think that it might be contraindicated, but not. I mean, I can definitely do massage to just my arm and not touch any of the rest of my body, and it won't really impact me, but I'm a healthy person and this is a person after surgery. I would definitely ask the surgeon why you couldn't massage all the way up to the lymph nodes, and because that would directly affect, that's where your fluid is going to. So I want to know why.
Yeah, I would have to agree with you on that. That why is it that they're being told they can't do it? So, and the only thing I can think of is that maybe their immune system is or the lymphatic system is compromised. Maybe there's nodal removal somewhere, which may be the reason why you can't. And then that is a different scenario, because then this is not a healthy patient. This is somebody who has had previous disease or injury, and then it's a difference between the CLT versus the MLD being able to handle the appropriate patient.
Yeah, but as a CLT, I'm still, unless that was directly where they had the surgery, which you can do if you're doing a lymph node transplant, absolutely. Like that's a specialized thing. You need to talk directly to the doctor, because, and then this is more of like, there's classes, NCBTMB classes on after lymphatic surgery. And if you're having a lymph node transfer, it depends on the MLD direction, depends on where on the limb they're putting that lymph node transfer. It's definitely something you want to have an extremely close relationship. That person will probably have a physical therapist and an oncologist and their plastic surgeon to talk to about that. But the direction, if you transferred the lymph nodes or if the surgery was right over the lymph nodes, definitely that's something that you need to go back to the doctor and have a clear conversation before you just try to do a massage.
Yep. Okay. Any more questions?
And there are a couple on the topic of fibrosis, asking whether that's the same as scar tissue. Or
so fibrosis is a scar tissue because like we can have scars all over our bodies in different layers, but this is different from like our incision makes a scar. It's internal.
Mm-hmm. Dr. Horowitz, maybe you can explain fibrosis in a little bit more detail.
Yeah, I would agree. I mean, I think like the cobwebbing that you demonstrate, just imagine that's scarred, and fortunately, from a surgical point of view, it could be very hard to deal with. It could be deforming, it could, adhese the skin down to the underlying muscle layers, and it could be very hard to deal with once it's set up. So the key is to prevent it.
And we do have some really, really good journal articles on with photos and explanations on different kind of side effects after liposuction. That's something I always, if someone wants to get into this, definitely take a look at those journal articles and know what you're going to see before it comes on your table.
Yeah, many of the references that we used for this presentation, if you were to go to any of those journal articles or textbooks, you can see some of that information in there. So they're good references. Yes. Any more questions?
I think we have time for one more, and I think this is a good way to close it out. The question is, how do you work consent with the patient and client and the physician so that you can report back to the physician, especially if you don't have a relationship like you do, Robin, with Dr. Horowitz, where you work in the same office? How do you handle that? What are some tips there?
Oh, well, Kathleen's probably the better person to answer that question. Go ahead, Kathleen.
Yep, every client should be filling in and signing a health history form, and it's in that last paragraph. I just put, where we're talking about massage, what massage is, what it isn't, what you're gonna have happen, and I just add a line to the effect of, you're giving me permission to share information about your case with your personal plastic surgeon. And they sign that document, and then I verbally tell them I'm going to send the massage therapy care plan, and then I send them an email the day after surgery, a day after their massage appointment, asking them how they're doing, and that's part of my massage therapy plan that I send to the client, that I send to their plastic surgeon.
So it's just a more elaborate, informed consent with medical, permission, basically what medical records release or, permission to discuss, just like you would do in any other doctor's office or any other healthcare provider's office. So. All right.
And
Well,
usually
I think, oh,
really love it. Like that's when they hear that, it's like, oh, so I am being taken care of as a, care team. It isn't like this person's never talking to that person. And I was like, no, I'm always, your surgeon says my name, I say her name, and we have a relationship with each other.
yeah. And I know Dr. Horowitz and I have that relationship too. And the patients definitely feel much more comfortable when they know that he's referred me to them and I keep reporting back to him. So
Yep.
absolutely. Well, this has really been a great webinar. I really have enjoyed this last hour with you all. So thank you so much, Dr. Horowitz. Thank you so much, Kathleen Lisson. And Dolly, I'll see you again in another month or so with our next webinar. So, I mean, we just get to spend more time together over the next year as we do more of these webinars together. So
I look forward to it. Thank you.
Great, great. Well, thank you, everyone. We really appreciate you joining us. We hope you have a good evening.
Bye.